thank you for taking your time and agreeing to do this for us. It's going to help a lot of people out with your condition. So I'd like to start off with just telling us what your condition is.
Well, what happened approximately January 7, 2002, I woke up to a severe brain aneurysm, which left me with paralysis on my left side,
Okay.
from neck down. After months of therapy was a drop foot.
The diagnosis.
The diagnosis, exactly.
You had a drop foot from your aneurysm, so they prescribed an AFO for you, for your drop foot, to help you.
Yes.
Good. And you've been wearing the conventional plastic AFO since then, since 2002.
Yes.
Until the doctor prescribed an Arizona for you. And what I want you to do is tell us the difference now that you've been wearing it for a few months, how you've been feeling, and tell us kind of the difference between this one and the conventional one you wore for several years.
Well, the difference is starting off with the old brace. The old brace is much wider, bulkier. It has a lot more bend and twist in it, meaning that my foot always had play, some certain degree of play in it. So because of that, I would have to buy two different sizes of shoes, at least a size and a half bigger on the brace side versus my regular side. And because of all the twisting and turning in the play in the old brace, I would have to, as soon as I was done, I'd go home and I'd have to take that thing off immediately. Yeah, I mean immediately, because of all the soreness and all the indirection that I had with the old brace.
Okay. But since you've had the Arizona that wraps your ankle on, how does that feel, and what's the difference between it now?
Well, since I was prescribed the Arizona AFO, I mean, it's more of a tighter fit. The shape of the brace
more
is
intimate,
yes,
more supportive.
Yeah, almost like a glove. I mean, we're talking around it, over it, under it, everything. I can actually go out all day long and still keep my AFO brace on until it's time to go to bed, versus when I used the old one, it would hurt me so much I'd take it off and then I'd walk around the house with no brace at all and tripping over the...
And also you were telling me that you've had several made. I mean, you know, the plastic ones. It's
yes.
not just one, but you've had maybe one every year, every couple of years.
Yes, I have a little collection.
Yeah.
The other ones were basically all the same,
Good.
Just a lot more. But this just has the greatest support. It completely wraps around my foot, around my ankle, and up to the bottom portion of my leg.
How about your fatigue, or you get more tired with the other one? Did you experience that? Did you experience with this one, you're able to do more with
well,
it?
put it this way, with my old brace, I have a scooter that I used to lug around with me all the time. Now with Arizona AFO, the scooter's been parked, collecting dust. So it stays on until literally when I go to bed.
Great. It's good, David. Thank you again.
You're welcome.
This is the casting procedure for the STS molding sock. First, the black strip is applied to the patient's limb using some tape. This just serves as a barrier to prevent the skin being cut when the cast is removed. Second, there is a flexible tube that then is applied over that, which will also serve later to assist in removal of the cast. This also now is just taped in place. As you can see, we have the patient seated, hip, knee, and ankle all at 90-degree angles whenever possible, and his foot is placed on our footboard. It's very important that you wear gloves during this procedure, as the material, once it's wet, is very sticky and will adhere to your skin. A plastic bag comes with the STS sock, and that is to be applied over the patient's limb. You then open the package of the sock, remove it from the package, stretch it open just a little bit and soak it in lukewarm water for just a few seconds. Wring out the excess water, and you're able to open the sock and roll it over the foot and up the leg until it's completely unrolled. Once it is unrolled all the way up, you can wet your gloves and then start massaging the material, which is the resin in the sock, to make sure you have a uniform spreading of the material so the sock will have a good consistency that way. Place it back on the footboard. Then take scissors and just cut a small hole at the end of the plastic tube. This is going to help facilitate removal of the cast. For training purposes, what we're showing you here is if you need the cast for, say, like our extended AFO that goes up over the calf and your sock was too short, you can use another sock. You open it up, cut the toe end off, soak that in water, just like you did previously. And you slip that over the current sock, pull it all the way over, just till where you're going to overlap it with that sock, about 3 or 4 inches or so. Then unroll this sock all the way up the rest of the leg till it's up over the calf. Quite often, just due to foot size and leg volume and shape, if you need to come up over the calf, you do have to use 2 socks like this. So now you just smooth it all together again, rubbing it in, and it'll all become as one. We then take the scissors and just cut a small cut at the very top of the sock also, right at the plastic tube. We then mark any bony landmarks or problem areas that we want to pay special attention to. Then draw lines across the anterior of the sock so we can realign it once it's off of the leg. Now it's important to hold the leg in the position you want the brace to be made in, as much subtalar neutral as possible, and as corrected as the patient is comfortable with. It only takes a few minutes for the sock to set up to where it's then ready to be removed from the leg. You're able to tap it with a pencil actually, and you'll be able to hear that the sock is kind of hard, and you'll know then it's about ready to go. You're able to then do any final markings with your indelible ink pencil on bony prominences or problem areas. Now, to remove the cast, you begin by removing the plastic tube that you had taped onto the leg. This leaves a channel in the cast that allows the scissor to go down the channel for easy cast removal. Just insert the scissor, cut the cast from the top and the bottom. The black plastic strip is still on the patient's leg to protect it from any injury from the scissors. The cast is then removed from the limb. The plastic bag should be pulled and discarded at this time. Now there's your finished cast. You can apply some rubber bands or tape to it to secure the opening by lining up the lines you've drawn. Now we're applying the extended Arizona AFO onto the patient. The patient would need to wear a cotton sock, ideally. Brace is slipped over the leg, just made sure everything's in place. You begin lacing it fairly snug, from the bottom up. In this case, we have eyelets and boot hooks. It's wrapped around the boot hooks, just tied snugly. Then the calf strap and the calf pad is applied over the shin. The strap's just put through the loop and pulled back over. And you're just checking then to make sure everything looks like it's lined up properly and fits appropriately, the length and the width, etc. And then a shoe, like an athletic shoe. If it has an insole, you'd want to remove that first. Slip that over the brace, and then apply whatever type of closure it has, either lace or, in this case, it has Velcro. And it's all ready for the patient then to start ambulating and to check out the fit and function of the device. This is this patient that was just seen fitting and casting, walking without the assistance of any type of an orthopedic device. As you can see, he has a very hard time on his left side dorsiflexing his foot and walks very much with an unstable gait. This is his old device. It's a plastic AFO. You can see he walks much better. However, he still had pain and discomfort, especially on the lateral malleolus. You can see there's some roll out there, and he was losing some of the control that way. The most benefit of the Arizona AFO styles is the addition of the leather gauntlet. This applies much more total contact fit around the malleoli as well as the midfoot and all the bony prominence areas. Pressure is relieved, and there's much more comfort for the patient and much more patient acceptance with it. You can see now he's got no problem clearing his toe when he walks much more stable. Footwear plays a vital role in the effectiveness of any orthosis. Here you can see we used some depth inlay footwear that has reinforced heel counters, a flared sole, and a good rocker to the shoe. All of this greatly assists with the ambulation and the overall effectiveness of the brace. The end result is you have provided a very effective system for your patient.